Good morning, everyone, and welcome to Perf Web 90. Oops, I have to turn off my sound. So sorry.
Echo.
Had a little bit of feedback there. Anyway, it's great to see y'all. This is the replacement program from last week. We have just been getting hammered at work, and I apologize for the need to reschedule, but I think it's going to be worth it. I think this is going to be a really good program today. Let me get through all of the typical housekeeping notes if I can. Of course, you can find us. You want to reach out to us, send us an email, contact@perfusioneducation.com. You can find us there. And then also our call-in number is 832-239-5358. If you'd like to be live on the air, we would love for you to call in. It'd be fantastic. Of course, our scroll bar is always going down below there where it has all of our information on the FaceTime, the Twitter, the LinkedIn, and all of our websites and stuff. And our phone number is also there if you wish to reach out to us. So all the social media platforms and all that kind of stuff. In addition, I would encourage everyone to go to the iTunes store or the Google store, whichever it is, and or the iTunes, the Apple App Store, and get our critical care application for perfusionists. It has a number of sections to it, including perfusion, which includes your quick calcs for doing your bypass cases. It'll calculate everything for you, give you your predicted crit, all of your flows, everything that you might need. It has an ECMO section. It has a conversion section. It has a hemodynamics section. It has an IV rate and dose calculator, which is actually also sold as a separate app, which is very useful for critical care nurses to be able to calculate things. You've looked at it. You've used it, I believe.
Yes, I do use it.
Vicky, my partner over here. And in addition to that, you can get that separate. But this is a very comprehensive app, and it's $1. How much is it? $2.99? Magic? $1.99? Yeah, it's very inexpensive. Look, it's it's really, we're going to go up on the cost of this eventually, because we put a tremendous amount of resources into it. And the standalone app is only 99 cents. So you can really, I think, do yourself a favor. It's great for ECMO specialists, perfusionists, nurses in the critical care unit, intensive care medicine docs. It doesn't really make any difference. I think it's a very useful, has high utility. Okay, moving on from there. Our podcast, you can find us on whatever your favorite streaming software for podcasts is. We're on all of the platforms. And you can listen to us in the car, on your way to work, stuck in traffic, whatever the case may be, or in the evening. I'm sure there's nothing more better that you could possibly think of to do than to listen to a Perf Web podcast. I mean, that's better than going to the movies any day, right? Okay, and so enough of that. I'm here with my colleague, Vicki Carlisle, our director of ECMO specialists. She is a critical care nurse of many years, and additional to that, she is an ELSO certified adult ECMO specialist, and she's operating that part of our division of our organization. I highly recommend that if anyone has an interest that is either an experienced ECMO specialist or wants to attend ECMO specialist training, because we're offering that now. We don't even have it up on our opening remarks, but we have a tremendous adult ECMO specialist course. And David, in the future, let's add that to our opening remarks. I think that would be very helpful. That program makes you eligible. Taking that program and having the hours, right, at taking care of ECMO patients gives you eligibility to take the ELSO ECMO specialist exam, the adult ECMO specialist exam. So that is differentiated. You have to remember that. We do adult only. There are pediatric certifications, but we don't do that. But those also do exist. All right, one last thing before I get started on my lecture, because I think you're really going to enjoy this lecture. I put a lot of time and effort into it, and I think you'll find it at least, I hope, very interesting. but also perhaps a little bit entertaining. But I wanted to show you this hat. Everyone is familiar with the MAGA hat. It's easily recognizable. And at first glance, that's what you see. But I'm going to put it on and ask if you could focus in on this. I don't know if you can. So I'm going to put it on, and these you can purchase from us. This is a mega hat. Make education great again. It's a little out of focus. That's okay. There you go. That looks beautiful now. What do you think? You like it? You want one?
No.
Okay, but
Can you make mine a different color?
It's a mega hat. Well, no, a perf web is red. It's a mega hat. I should wear this for the entire. No, it's red. It's we. Yes, not today. Right. Okay. So let's go ahead and jump right into my slides. A little fun for today, a little entertainment. Okay. So the fundamental question here, the premise of my lecture has to do with pulsatility on cardiopulmonary bypass. And the question is, for human physiology, which came first, the pulse or the heart? So is the pulse just really a result of the way the heart is designed, or is the heart designed to accommodate what's necessary for the pulse, for the pulsatile pressure? Yes. Let's do the quote. You have a quote. You want me to read it?
Yes.
Okay.
Your delivery is better.
It says, presence of a pulse may represent nothing more in physiologic terms than the expression of the limitations of the organic heart design.
Which answers your question.
Well, yes, this is Wesolowski. Doesn't mean he's correct, but it's certainly a good quote. So let's move on from there. I'm sorry? Okay. Yes, Veselovsky, excuse me. So proper pronunciation says the guy who can't keep the lights on. And so here we see the heart is beating. And on the right side, what I want you to do is watch as the initial wave propagates out, that's represented in blue, and then a reflective wave that comes back. And if you look at that vessel, you see how much elasticity that it has, and it has decreasing elasticity as it gets farther and farther distal. And this is something that is going to be very important for everyone to remember and think about as I go through this lecture. And I'm going to show this very slide again and parts of this slide as we move forward. But you see the blue is the incident, and then you see the reflective wave coming back and where that reflective site is and down below. So you can kind of take a look at that and just sort of get a feel. I wouldn't study it too deeply. And there's the heart over there diligently beating. Here is yet another representation of this same phenomenon of an incident wave and reflective waves. And if you look at the blood pressure waveform simultaneously in the aorta, the brachial, the radial, and the femoral, and those are those lines that you see from top to bottom, those waveforms, you see a very different waveform morphology between these various different sites of measurement. And that has to do with incident waves, reflective waves, and something that we're going to refer to a few times called SHE, S-H-E, which is surplus hemodynamic energy. And we'll explain a little more of that as we move forward, right? If you have any questions, don't hesitate to interrupt me, please. And if anybody has any questions there, I'm looking at the YouTubers right here, so you can always just chat in a question or just call in and interrupt me. That's no problem at all. So the definition by Webster of pulsatility is a rhythmical throbbing of the arteries as blood is propelled through them, typically as felt in the wrists or neck. And then you can also have sound pulse generators, an injury that is throbbing pain. So there's all kinds of different things. But we're really talking about arterial pulsatility, not necessarily just the idea of a pulse, because there is a vast difference. Normal human physiologic pulse pressure is plus or minus 40 millimeters of mercury. So 120/80 is usually what we know as the normal blood pressures. That's 40 millimeters of difference as a pulse pressure. In stat pearls, and going back and looking at this, and this is very, I think, critical to really read this and in whole. A normal young adult at rest has a stroke volume of approximately 80 milliliters. So they may have a volume of 100, 120, and their ejection fraction is somewhere between 60 and 80%. There's always left over, right? But it is 80. Arterial compliance is, and that's the elasticity, right, is approximately 2 mLs per millimeter of mercury, which confirms that normal pulse pressure is approximately 40 millimeters of mercury. Because the aorta is the most compliant portion of the human arterial system, the pulse pressure is the lowest. Compliance progressively decreases until it reaches a minimum in the femoral and saphenous arteries, and then it begins to increase again. This concept requires an understanding of the effect of pressure wave reflection of the amplification of aortic pressure and thus pulse pressure. Again, going back to surplus hemodynamic energy. The phenomenon mainly occurs in the lower body, especially the lower extremities, where pressure waves reflect back due to vessel branching, and the vessels are less compliant. When a reflected wave is in phase with a forward wave, it generates a wave with higher amplitude. An analogy is our waves bouncing off a seawall interacting with the incoming waves that are in phase, and the wave height becomes higher. A pulse pressure that is less than 25% of the systolic pressure is inappropriately low or narrowed, whereas when it's greater than 100, it's high or widened. But what's critical here is that 25% is inappropriately low or narrowed. So if you have a systolic blood pressure of 100, you should have a pulse pressure of 25 minimum, in order for it to not be inappropriate and thus ineffective. This article, written in the Journal of Extracorporeal Technology by Tan and colleagues, I thought was excellent. I would definitely screenshot this or write this down. This is a very comprehensive, worthwhile organization. Let's see, I got a thing here. Hello, great, thanks for the topic, and I have some important questions. When I'm doing on pediatric, and of course calibrate my pump every time, and during cardioplegia, most see pulse wave on the monitoring. It's twice higher than pump rate. What's that? That's a good question. I'm going to have to think about that for a minute. I'm going to get back to that as we go forward because I'm not 100% sure I understand it. And remember, I don't do pediatric cases, but I might answer your question as I move forward here. Anyway, this article is a great article. What they did was looked at papers over a 25-year period. It was a review from 1995 to 2020. And in their sort of dialogue, they discussed that over 1 million cardiac surgeries are done worldwide, most on CPB. And for record, very few with pulsatile perfusion technique. Of course, it affords a bloodless, quiescent surgical field. We recognize that CPB is not without its own inherent risk. If we take a healthy person that does not need cardiac surgery, and we put them on cardiopulmonary bypass, they're going to feel very sick for a little while. There's going to be a recovery period. It is not without its own risk. It could potentially be lethal. That would be rare, but anything can happen. This is when you put people on cardiopulmonary bypass, it is a big procedure, not something that's just, we're just putting them on pump. Much the way ECMO, you put somebody on ECMO, if they don't need to be on ECMO, they're not going to feel great about it. It's going to have, there's going to be things that occur.
Sure.
Okay. Overwhelming majority of these cases, again, are done with continuous flow, and efforts to mitigate some of the deleterious effects of CPB include the use of pulsatile flow perfusion. With that said, I have to readily admit, normal physiology is pulsatile, and there are things that happen when you take that pulsatility away that aren't good. I'm not going to dispute that, but let's talk about pulsatile perfusion via the cardiopulmonary bypass circuit. It is a different topic. We use centrifugal pumps and we use roller pumps. No, we do not use double roller pumps. We use centrifugal pumps exclusively, but I do have some good data on roller pumps, but we would use a single. Pulsatile flow is controversial for many reasons, notwithstanding our base physiology is pulsatile. Again, it's intuitive. Our perfusion circuit should be providing pulsatile flow because that is what is normal physiology. The question is, are we providing pulsatile flow with our extracorporeal circuits? And if we are, is that pulsatility adequate to meet the physiologic requirements of our arterial systems and our bodies? The benefits of pulsatile flow, again, pulsatility, and not necessarily just via the cardiopulmonary bypass circuit, but it's important to note that the European Association of Cardiothoracic Surgeons, the European Association of Cardiothoracic Anesthesiology, and the European Board of Cardiovascular Perfusion guidelines on CPB, not recommendations, guidelines, in adult cardiac surgery recommend that pulsatile perfusion should be considered for patients at high risk of adverse lung and renal outcomes, while recognizing the lack of strong evidence for beneficial effects. Concerned that pulsatile flow modes may also have deleterious effects have persisted, with some evidence that in some CPB circuits it may increase levels of hemolysis. Therefore, plasma-free hemoglobin, which we know is nephrotoxic, it also has effect on nitric oxide. There's a lot of bad things that happen when you are shearing red blood cells. In view of the continuing controversy over the use of pulsatile flow, this review aims to summarize the suggested physiological mechanisms by which pulsatile flow may benefit patients and examine the current clinical evidence surrounding the use of pulsatile flow during CPB. And again, this article is really wonderful. I strongly advise people read it because it is comprehensive as could be. But there's several other articles that were relied on for this lecture today. So some of the benefits of pulsatility are better preservation of the endothelial glycocalyx and production of nitric oxide, which preserves vascular homeostasis, vasomotor tone, vascular permeability, inflammatory response modulation, and a physical barrier to leukocyte extravasation. In fact, when you go on cardiopulmonary bypass, there is definite damage done to the endothelial glycocalyx. And this will last for up to 3 days following cardiopulmonary bypass before that repair takes place. I think that's the same phenomenon we see a lot of times with ECMO patients.
Yes.
I'm not 100% sure it's only a result of the loss of pulsatility. I think there may be other reasons for it, but loss of pulsatility has been shown to damage the endothelial glycocalyx. If you have pulsatility, you preserve your renal function and other end organ function, vis-a-vis pulmonary, splanchnic and hepatic, cerebral, hematologic, microvascular and inflammatory processes, cardiovascular, and improved length of stay and mortality, if you can maintain that pulsatility, based on the data that these authors relied upon. The problem is, when they looked at all of this vast information, they found that urine output is frequently used to assess renal function, and that's likely because it's so easy to do, and I agree with that. But most studies, the overwhelming majority of the studies, reported either no difference or an actual decrease in urine production when you're using pulsatile flow via the cardiopulmonary bypass circuit. Creatinine and creatinine clearance showed no benefit. Using other markers than creatinine, vis-a-vis NGAL, showed no improvement, and rates of AKI and ARF, acute kidney injury, acute renal failure, were no different. So they found no benefit in these things. And their paper goes on to really look at all of the various organ systems and a whole host of articles, all showing no clear benefit, and really not even suggested benefit, except for a few spattering of very small, underpowered articles that were written. So not strong evidence. In fact, there's stronger evidence against in their article, in their review, than there is for. In this article, written in, I believe this came out of SIO, or the Journal of Cardiothoracic and Vascular Anesthesia, I'm sorry, the association between pulsatile cardiopulmonary bypass and acute kidney injury after cardiac surgery. They did a retrospective review, looked at 3,000 patients, utilized the KDIGO definition for AKI, and they found no difference between the groups using pulse or versus using, whether it be centrifugal or roller, or using continuous flow for their cardiopulmonary bypass. So again, no benefit. They looked at the same outcomes: pulmonary, cerebral, hematologic, length of stay, mortality. And what was very interesting to them, and interesting to me, was the only improvements, which were not really clinically significant, the only real improvements seen in renal function had to do with patients that the balloon pump was in, and that's what was being used to generate the pulse during cardiopulmonary bypass. Now, we all know all patients don't have balloon pumps, and we're not about to put balloon pumps in every patient that we're going to put on cardiopulmonary bypass just to generate some level of pulsatility. That was the only improvements, but the improvements were very marginal, and you really can't say one was because of the other in this article. So the results were mixed, with no conclusive improvements in outcomes, basically the same. In this particular article, they looked at the hemolysis rates, and this is from Tan and crew, and I'm not sure where this article was done. I don't remember at this point in time, but in Clinical Cardiovascular, I don't remember what country they were from, but they looked at pulsatility and red cell shearing, and basically what you see, and I'll go to the next slide and blow it up for you. Oh, I'm so sorry. That's my glasses.
You need them?
Yeah, probably so.
Let me grab them.
I'm sorry. You look at the plasma-free hemoglobin levels, or the globin levels, and you see that as soon as within 5 minutes of bypass and going on pulsatile flow via the CPB circuits, you see the hemoglobin levels rise. They peaked at about 30 minutes, got a little better, and that could have been dilutional. But then you see again, they're quite significantly higher after protamine when you're terminated bypass, and presumably the hemodilution effect is going to be less. So we all understand that plasma-free hemoglobin and red cell ghosts, damaged red blood cells, are detrimental, are damaging, are nephrotoxic to the kidney and can result in acute kidney injury. So I think what I found when I looked at all of this data, all of the studies that were done, there is not any level of even close to conclusive evidence that creating pulsatility for cardiopulmonary bypass is beneficial. Whereas, from what I read from the papers that you can reference from this lecture and go and look at yourself, there's actually risk. And I, in my opinion, would not recommend the use of pulsatile flow for cardiopulmonary bypass, whether generated by a centrifugal pump or generated by a roller pump, even though a roller pump will probably generate a more physiologic appearing pulse. I think that the use of the roller pump for generating a pulse on bypass is extremely risky for having a line separate, rupture of a line, or possibly air cavitation. So I don't feel that that should be done. So what if I told you that this is a pulse? Really, that's kind of where we're going here with this. And you see over here on the right side, again, looking at the pulse in the carotid versus looking at the pulse in the femoral. They're very different morphologies. Now, let's take a look at this. There is a pulse pressure, and you're looking at it right here. That's the pulse pressure being generated by the cardiopulmonary bypass system. 67, 77, 87, 91, 24 millimeters of mercury. That's not bad. 24 millimeters of mercury is what this pressure, pulse pressure is. And that's almost ideal. That's really perfect, right? But look at the wave. Look at it, how elongated it is. It sort of goes up. It looks more like a sine wave. That does not resemble this in any way, shape, or form, in my opinion. Now, let's go over all of this because I think this is very interesting. Everything is time-stamped. So you're going to know what time it is, all right? So when you see how fast our surgeons are, you're going to want to come here to work, okay? So this is how fast we are. Here's our radial pulse, okay? 99 over 52. That's 47 millimeters of mercury, right? 47, okay? That's good. That's 40 plus, right? That's good. Here is going to be, the white is going to be my arterial line pressure, and I set it up on a transducer right next to the radial where we're measuring this. Where we're measuring this and measuring this is exactly the same place, the same height, everything is the same. The only difference is this is coming from the right radial and this is coming from the pump circuit. Okay, either pre or post oxygenator, okay? And here's our sat, here's our temperatures, here's our heart rate, our CVP's 9, okay? Looks good. And they're just taking the mammary down. This is the same patient, it's 917, little artifact on the EKG. Our pulse pressure is now 40, 50, 52. 52 is our pulse pressure. Our CVP is 10, SAT's 98. Our still temperatures are here. We're not cannulated yet, so you don't see anything there. That's just the pressure in the pump circuit. Here's the arterial line. This is Denise. I told her that I would show this. Here's Nisi. Okay, we have fun at work too. Here's our arterial line. It's now 9:35, and we're on bypass. So you see here, initiation of bypass, I have a mean pressure of 42. My arterial line pressure post-oxygenator is 154. There's some variation, but 154 on the mean. And we've just initiated bypass. We're not cross-clamped. You see an EKG there, okay? And we're having fun. But I'm not happy with this pressure. I need to get it up. I've probably given a little bit of either phenylephrine or norepi, one of the two. I can't remember which I was using that day. And that's just a blow up of what we just looked at. So I'm still running a little low. We haven't cross-clamped yet. It's still 9:35. But I went ahead and turned on the pulse. You see here 46/39. And that's probably a compliance issue. I really do need to get that pressure up. But let's look at the circuit pressure. And this is in the arterial line post-oxygenator. 343/11. That is the pressure in the arterial line post-oxygenator going up to the table. It's right there at the pump. And you have the arterial line going up to the table and then into the arterial cannula into the aorta. The mean, what we see, because we use a pressure dampener and mean pressure, is 182. I was flowing about 5 liters at this point in time. That's not bad, having a mean pressure of 182. And I'm not too happy with this pressure right here. Again, I'm still treating it. It's come up to 936. We're still not clamped. Flow is 5.15. Patient's pressure is 48/38. I now have a pulse pressure of 10. And I'm still trying to get that pressure up, but it's only been 1 minute, right? But I went and switched to pre-oxygenator pressure, and this will only read up to 350 millimeters of mercury. We are off the scale. I have no idea how high it really was. I'm assuming it was somewhere between 350 and 400 because I exceeded 350. That's why we have the dashed lines. Okay, and again, flow is that. Here's my line pressure. Line pressure is actually, but of course now I'm measuring it before the no, this is actually post-oxygenator. This is measuring post-oxygenator. This one here. Okay, now this is a video, and we're going to watch the video, then I'm going to break the video down. There's my flow. Here's my mean pressure. We're cross-clamped. This pressure is 67, much better. Now you're going to see my finger push pulse. You see the line starting to jump right here. You see I'm generating a pulse there, 347/27 with a mean pressure of 63, and I have a 72/63, 9 millimeters of pressure. You can actually see my effluent pulsing because some of my pulse, now it's 91/67. So let's see, let me pause this. 91 minus 67, 8, 11, 4, 2. I have a 24 millimeter of mercury pulse pressure. That's what we're looking at. And again, you see it, what it looks like in comparison to what's being generated here. What's being generated here actually kind of does look a little bit like a pulse, but it doesn't look like one here in the patient. Why? That's the million-dollar question. Why? And I have the answer to that. Oh, I can't make this go away? How come I can't get rid of my marks? I got to close this and reopen it. Oh, I can't get rid of my marks. Oh, I can. I'd have to do that. Okay, good. So we'll watch through this again. Lots of things happening here. And you see the time, 9:59. 4.68 liters. 202 on my line pressure. I just hit the pulse key. You see right here, this pulsing? I wish I hadn't done that. Maybe I just used my dot. There.
There you go.
There we go. 70 over 53. That's about 15 millimeters. You see the effluent here pulsing through my hemoconcentrator. You see the line pulsing. You see what looks like a really good pulse here. But here in the patient, is that a physiologic pulse waveform? I'm just going to ask you.
No.
In your view.
No.
Would a patient like that do well in the ICU? If that was their native heart?
No.
You think they'd be on some drips?
Yeah.
Mm-hmm. That's what I think too. And here it is. I guess I have to do this every time. I don't know why that's doing that. There. Okay. Yeah, I'm not logged in. I think that's part of the problem. So there you go.
That's
Mean pressure is 80. This is a close-up of it. This is actually not pre-oxygenator. This is post-oxygenator, still exceeding 350. So that's why this number's here like this. Means 210. I'm flowing again about 4.7, 4.8 liters per minute. We're warm. And this is the pulse waveform that you see. Very sloped, very slow, very elongated, and not much of a crisp upstroke like you would normally see with a pulse, right?
Correct.
Very, very, very different. I'll play these two together. I want you to look right here. I want you to watch as the pulse occurs within this oxygenator. And what I said about roller pumps earlier is when you see what I'm going to show you, I do worry about micro air. And I just want you to look at it, really look at it. And then I'm going to show you this video over here. So let's look at this one first. Do you see that? Were you able to appreciate that?
Oh, yeah.
Here's the line jumping. Okay. Line jumping. And we're going to look up here. And there's a 15 millimeter pulse pressure. It's now 10:11. You see the time there. 337 over 26 being generated post-oxygen. Yes, post-oxygenator. So the arterial line to the arterial cannula. Now let's look over here. And what I'm going to show you here is this line. I'm going to grab it. I'm going to show a close-up of it. And I'm going to pause it right here. The difference in this tubing from an aorta is that this tubing is designed to be highly compressible, but it has a wall thickness of 3/32. Mm-hmm. I don't care how much radial force you apply to it, it is not going to distend.
No.
All that's going to happen is increasing velocities and pressures within it. It won't distend and contract, but it is highly compressible because you have to be able to clamp it to stop the flow. And I'm going to play that a couple of times so you can look at it and see it for yourself compared to what I showed you with that diagram of the aorta, which is pretty representative of the real thing. All it's doing is bouncing.
Right.
It's not pulsing. And show it one more time. Okay. So what you're losing in this is you're losing your surplus hemodynamic energy.
Yes.
It doesn't exist in this because it's not distending and contracting naturally. And because, and I'll get into that here in a second, so the question is the pulse pressure generated by the CPB circuit physiologic? And what are the potential risks versus benefits of attempting to pulse? If it's not physiologic, everything we do carries risk. There are, I think, real risks, which are intuitive, but also demonstrated in published literature. Why is this phenomenon the way it is? Well, if we take a look at an aorta, an LV, an LVOT, which is here, which is muscular, and the ascending aorta here, the LVOT is somewhere between 2 to 2.2 centimeters, let's say 2.5, and the ascending aorta is 3 centimeters. The cannula that we're using to flow through, not only is it not muscular like this and part of the LV contraction, which shoots the blood into the aorta, into a space that's 3 centimeters, we're taking a 7 millimeter or maybe an 8 millimeter cannula, sticking it in here and expecting it to do the same as an LV ejecting into the aortic valve, into the ascending aorta. Likely not a good match. It is such a tremendous size mismatch. Therein is the problem. And here is an excellent representation of this. Here is the tip of the aortic cannula that we use. There's many, many of them out there, I realize that. But in our particular case, this is rigid. It's small. It has no distensibility. It's pretty stiff. And it goes in the ascending aorta in this configuration, pointing distally, as you see here, and you see the blood coming out. Here's another representation. You see all of this space. This is not how the LV ejects into the aorta. It doesn't look like this at all. And we're attempting to generate the same flow dynamics that you would have with an LV ejecting 80 cc's in a very brief period of time.
Very brief.
By ramping up flows in an artificial circuit going through a hole not big enough for those differences in those differences in that flow. So you're trying to put a big increase in flow in a short period of time through a hole not sized to accommodate it. So that's why it has to be done over a longer period of time, and why you see that reflected arterial pulse wave that you get in the patient as slow and very low, because it can't eject the volume of blood an LV does in the same period of time to result in what is a physiologic pulse. Now, that all made sense?
Yes.
Okay, any questions? Aspirate air through the poly. It is absolutely, Anil, you can absolutely draw air through your microporous hollow fiber membrane, whether it be, it's not true membrane, microporous oxygenator, whether it's polypropylene or polymethylpentene. Polymethylpentene is plasma tight. It is still microporous. So yes, you can absolutely suck air, and there are articles that have demonstrated increases in micro air by doing this. So excellent question. So here again, is it correct to say, yes, is this, you see we've come off bypass, and this is very interesting because I think this is a common phenomenon, and it is a result of a loss of pulsatile flow. So I actually can show why pulsatile flow is good. The problem is we don't do it well and shouldn't do it with the circuits we have. If you want to do it, You need to transect the aorta, put a graft on it, have a much shorter arterial line, have a pump that ramps up speed much, much, much faster, and don't have a size mismatch. That's the problem. The length of the tubing, the lack of elasticity of the tubing, not compressibility, but elasticity, being able to get bigger, the loss of the surplus hemodynamic energy trying to jet through a small cannula into a big space, it is not sufficient to generate a physiologic pulse. But what you see is this is the pressure in the aorta compared to the pressure in the radial. This improved over time, and they eventually came to match each other. You see, it's 10:55, so I'm out of there, out by noon with no balloon. But that is that's a 60 millimeter difference in systolic blood pressure from the aorta, because it's coming down my arterial line. I'm measuring it in the same place I did while we were on bypass. So your diastolic is very low because of that length of that tubing, but the systolic is going to be correct. The diastolic's probably a little higher than this. You lose some of that because of the size of the tubing and the length, but the peak pressure is going to be accurate. And the aorta felt that hard. So this reason for this has to do with that loss of pulsatility and a difference in the vascular tone out in the periphery where we're measuring. So there's no question in my mind that there's a difference, that you lose vascular motor tone over time when you don't have pulsatility. But with pulsatility, you still have it because the pulse we're generating is not physiologic, doesn't work, and carries with it too high a risk. Here we talked about this. It's created by elasticity in the vascular bed, and this changes over distance, and it changes with age. When you have somebody that's old and they're vasculopath and they have rigid arteries, you notice a much more widened pulse pressure.
Sure.
We looked at this. We looked at this. Now we get to continuous flow total artificial heart. It doesn't matter whether you talk about Syncardia, Thoratec, HeartMate, Heartwear. These total artificial hearts that exist are continuous flow pumps. They've lasted 8 years on continuous flow pumps without pulsatility. The reason for it is durability. Trying to create a pulsatile pump is very challenging, and they tend to break. So the body over time will adapt to the loss of that pulsatility. Short term, not good. Long term, adapted. Here's, of course, Dr. Cooley, a wonderful human being since passed. Dr. Frazier, when he was a little bit younger. Dr. Billy Cohn, he's also a magician. And here you have the steer or the cow that is on a continuous total artificial heart. So when you look at all of these devices, they are, whether it be axial or centrifugal, these pumps are all being designed, the total artificial heart, as a continuous flow pump. But it just takes time for people to adapt to this new environment. So benefits of pulsatile flow via the cardiopulmonary bypass circuit, this is my opinion, but I believe that the data that exists, the good data that exists, does not show any benefit. The risk, I think, has to do with blood cell trauma. I think the risk is potential for air entrainment. I think there's risk for line ruptures. I think there's risk for that jet into the aorta doing vascular injury to the aorta. Just to name a few, and I believe that this is weighted with too high a risk for too little benefit, and don't recommend it. So when you're looking at your patient monitor, looking at your arterial waveform, you can't call it a pulse if it isn't a pulse.
I do remember that now.
Okay. Now, let's go to questions. I did answer Anil's. Bob Joe, thanks for the physiology education on why we can't mimic pulsatile flow, tubing not compliant enough, like a graft, small cannula, etc. That is correct, Bob. Bob Crawford, how are you? It's so good to talk to you. I haven't talked to you in a long time, man. I hope life is treating you well. But 100% agree. It is just not something that we can mimic unless, again, you have a very, very short line with your pump juxtaposed essentially to the aorta, and you want to transect the aorta and connect it to it. I think you could do it then. That seems a bit harsh, a bit severe to accomplish that for just a coronary. But it is what it is, right? I just don't think we're ever going to actually be able to do that effectively. And I think, again, I think the risk of so many things that can go wrong with that, it just isn't worth doing it. And I was surprised at how high those those pre-oxygenator pressures were, well over 350. I have no idea how high it actually went. It could have gone all the way up to 400. And I'm not sure that is, I'm not sure that's good. And then stop the pump. I mean, if it was a roller pump, stop it, and you have that tremendous drop. The pulse pressure was enormous in that, 200, 300 millimeters of mercury or more. I don't know how you could not potentially suck air in, if it were to go negative for any reason, into your through your microporous hollow fiber and then into the arterial system as small microbubbles. And actually, the data in that article that I first discussed, they actually do discuss greater numbers of, some of the articles that they read, greater numbers of gaseous microemboli that they were able to find in some of their articles. And if you read that review, they do not recommend that you do that you attempt pulsatility through the CPB circuit either. And I thought theirs was done very, very, very well. I probably didn't do it justice, but I was trying to sort of look at a whole bunch of different things and give you my take on all of this. You can change this warning level. So poor pulsatility, inability to support larger patients, even if the pulsatility is meaningful, which I agree it isn't. Yeah, that's the real issue. So absolutely, Karma. So the poor pulsatility, I mean, it's not anywhere close to being physiologic, and it's not stretching that aorta. You go up and look, and you don't see the same. If you look at an aorta off by, and I probably should have taken those videos too, but you go up next time you're doing a case and look at the aorta before you go on pump when it's beating normally, and then get on bypass, clamped, switch to pulsatile perfusion, go back and look at that same section of aorta, and you don't see it expanding and contracting as you would pre-bypass. So I think it makes an enormous difference. Pump rotating without, and monitors can display a pulse rate of, in the absent normal, which there's 2 peak periods. Yeah, these are, I'm going to try to answer it. So poor, with pulsatile flow on is close to reaching equipment limitations. That's right, at around 5 to 6 liters. Will warn me that exceeding the max pump rotation speed also. Yeah, I agree with that. So you're using a roller pump. And that's, to me, scary. I wouldn't do that. I'm, a lot of people use them and use them effectively. I'm just not used to it anymore. I trained on them. That's all we had. We didn't have centrifugal pumps when I trained, but I now use those and much, much prefer them. But I would be very, very uncomfortable doing, trying to pulse with a roller pump. I just see that as potentially very disastrous, and that's just my opinion, and maybe it's just my comfort level, but that's how I feel. So what did you think? Get your opinion. I've talked enough.
Well, you actually answered a lot of my questions already. Most have to do with this retrospective study that you were looking at. When they go back with these sort of studies, it's kind of convoluted when they go into these renal aspects, because they use like urine output and creatinine clearance and all of those things, which of course don't show that renal reserve that might have been lost during the case. The in-gall is good, but most of them don't use it.
No, I don't think we can even measure it here.
Yeah, so properly assessing renal function during those things in these retrospective studies is very tricky.
I think that you take a patient who comes to the hospital in order to do a real study like that. You take a patient, and before we've touched them, and we look at their creatinine level. Okay. Then we do whatever we're going to do to them, and we send them home. And we wait 30 days, 60 days. And we, after they get home, and they're back to normal again, then we check their creatinine level again. And or we look at their whatever their, we're going to use as their GFR, whatever. And then we look at it and compare it. I think that's the only way to really get a better assessment, because so much of the numbers that we look at are affected by volume distribution, their albumin levels, their nutrition intake, their protein levels. I mean, there's so many things that are going to affect it, the drips they're on. We just don't know.
Well, and
it takes
also
time.
Hemodilution. How much were they hemodiluted? Because that increases the urine output.
Of course.
Creatinine
Potentially.
doesn't increase
How many got Lasix?
Right.
So you need to know what happened to them 3 months, 6 months, maybe even a year later. Did they need to be on dialysis? That's a clear indicator something bad went wrong, right?
And you have to have a damage of considerable amount, almost 50% of your nephrons before you even see a creatinine increase.
That's a very good point.
So a lot of this could be hidden as far as the renal side goes, right?
Right.
The in-gall is good. I mean, nobody checks the renal reserve. You have to do that protein challenge and stuff for that, and it's just not practical. You talked about the oxygenator was a question I had as far as the pressure drop dampening that pulsatile flow.
Oh, I think the entire course of the circuit changes it, right? Your smallest point is that we use 21 French on almost everyone. That's 7 millimeters. So we use 7 millimeter cannulas on almost everyone. Up to 120 kilos, I'll use a 7 French. I have no problem with that at all.
Correct.
And most of the surgeons would much prefer a smaller cannula as well. But I'm not going to try to pulse through it. But some people want to. They try to. That patient that I was flowing almost 5 liters. I mean, that's pretty high. That's up to the limits.
Yeah.
Better off doing that case without pulsatility. But I wouldn't have had these videos then. So,
they showed the pressure drop effects on it really clearly.
Yeah, but not only
really
do you have that, but you then have this big, long length of tubing, 8 feet, and then it's going into an oxygenator, and then back out the oxygenator to where the pump mechanism is, and that also has a length of tubing. So what I did was put a 3/8 lower lock between the pump and the oxygenator, and that's where I measured my pre-oxygenator. So the oxygenator itself created a greater level of resistance than just the arterial cannula, but that is the tightest point. Okay. But you could see the blood changing in there. I'm sure there are some things that are internally actually expanding and contracting, but they're not vessels. They're not made of the same material. These are non-biologic pieces of fibers and plastics and so forth. So very different environment than what a human or a mammalian arterial system is made of. The tissue is very different. The material is very different. Which one is better to use during pump? Is mannitol or Lasix? Well, I guess it depends. You know, it depends on what you're trying to accomplish. If you use mannitol, you're looking for an osmotic diuresis. If you're using Lasix, it's a loop diuretic, and you know, they just work very differently. You know, I think if you have good flow and good perfusion and good perfusion pressure, and your kidneys are working, I think you probably don't need either. I tend to use, and of course, I'm very aggressive with hemoconcentration. You saw I had a hemoconcentrator in line. I try to come off bypass with the same or less volume than I started with, because I want to flush the entire pump circuit back into the patient when I'm done, as opposed to shifting it over to the cell saver. So I really try to if I use Del Nido, I'm going to take 1200 out. If I know my prime was 1200 cc's, I'm going to take that out. That's 2400 of ultrafiltrate there, minus whatever the urine output is. If it usually it's not very high, and our pump runs are relatively short, so really not a lot of time for that. And then anesthesia usually gives 2 liters of volume. So if I take 2500 to 3 liters out of that particular patient, if they have that kind of volume to take, then I will. Now, I prime all of my pumps with at least, at minimum, 25 grams and really 50 grams of albumin. I look at the albumin level before I start. If the patient is hypoalbuminemic, before I start, I'm going to give extra. We, tend to not see hypoosmolar patients, but I use mannitol more when the cross clamp comes off, because it's an old school thought that it will mitigate oxygen-free radicals, and that you can reduce the ischemic injury, reperfusion injury to the heart. That's when I tend to use mannitol more than I use it as a diuretic. Jehovah's Witness patients, the same, the same. Again, I'm very aggressive with hemofiltration, ultrafiltration. I don't wrap. That's my next lecture. I don't think wrapping makes any sense if you use hemofiltration appropriately. And I think that the risk of wrapping the things that can happen to the patient aren't worth it to me. I just don't find it worth it. I just think that ultrafiltration is a better approach than the delay of going on bypass. If you're really going to do it, you should mix. You should have the entire, and that's what we used to do in the old days, is take a little venous and add a little crystalloid with our circuit, and do that until we had the entire circuit filled with blood, and then go on bypass.
A little gentler.
Yeah, but now we just open the line and go on bypass. It's about a liter. You've seen that happen with patients that we've crashed on ECMO, right?
Yes.
When we changed an ECMO circuit, they have that period of time.
Oh, yes.
And that's why I started priming the ECMO with blood on highly unstable patients. I prime it with blood, bicarb, and calcium, and have that prime so that when we go on back on ECMO, we don't have that additional 20 or 30 seconds of instability.
A rough 30 seconds.
So circuit is basically the same for Jehovah's Witnesses. And again, if they accept cardiopulmonary bypass, they're likely going to accept the cell saver. But we do connect the line and prime everything to keep it as a contiguous unit system and all of that kind of stuff. So all of the appropriate maneuvers that we need to do to make sure that we comply and protect their particular beliefs. But again, ultrafiltration is very important to me because you're keeping all of the blood plasma and the platelets intact as you flush the concentrated blood from the circuit back into the patient, and not sending it over to the cell saver where you're only going to give red blood cells back and lose the plasma and the platelets. So those are kind of the way I do things. Any other questions?
For the hemolysis with the pulsatile flow, does that have as much of an impact on the nitric oxide and the glycocalyx as if you were just laminar flow?
I don't think it.
What's
I
the
don't.
comparison?
Yeah, I do think that it. I think those shear forces in that plasma-free hemoglobin being toxic. I don't know if that's damaging per se to the damaging to the glycocalyx as the endothelial glycocalyx as is the loss of that pulsatility, that rhythmic expanding and contracting of the vessel wall, and the shear forces that are associated with that blood going through that small hole at this high rate, sort of pressure washing the vessel, if you will. But I do think that elevated levels of plasma-free hemoglobin have just a generalized effect on nitric oxide production, and that it's problematic on its own merit, whatever that's caused from, whether it be rhabdo, from an injury or something like that. The same phenomenon is going to occur, but you're not using cardiopulmonary bypass. It's just because of the plasma-free hemoglobin.
So potentially the same effect whether you pulse or not, depending on the pathology that causes it.
Yes. Well, I think just the loss of pulsatility on its own merit is going to have that effect again, because you're losing that adapted and expected expansion and contraction. So all things being equal, loss of pulsatility in the short term is damaging. The argument is my argument is we can't create a pulse that is in any way mimicking a natural pulse, and that the risks associated with that are very high. So on its own merit, on its own merit, elevated levels of plasma-free hemoglobin are detrimental to nitric oxide production and utilization at the local level. And so I think that on its own. So if you combine both, I think that it's doubly damaging. Yes.
For sure.
So again, I think that if you take normal, healthy people and put them on cardiopulmonary bypass, they're going to feel very sick.
Yes.
For a period of time, just by doing that to them.
And then last question, we have one more time for one more?
Yeah.
Pushed on time. For the study, how do they quantify the pulse pressures given in these cases, and what's from one article to another article, especially in this retrospective, how do they compare and put it all into one study like that? The pulse pressure in itself can't be solely looked at without taking into account the pressures coming from the circuit.
Yeah, and that's such a good question. But that is what there's very, very few, and again, I told you that the spattering of articles that showed benefit and supported or promoted the use of pulsatile flow, according to the two specific articles that I referenced, both being reviews, one being a review of all the literature, one being a retrospective review of their data. Basically, the one that was the review had 98%, 99% were not supportive, whereas these few very underpowered, almost anecdotal articles, which were published, but what people are pointing to and saying, see, it says it right here. And I think their argument was that those are not good studies. You really shouldn't follow these. And the retrospective analysis was just that. They looked at 3,000 patients and they found no benefit. But then there's postulation, and I think the postulation is reasonable, that intuitively what we're looking at here in this circuit is very severe and very hostile to blood and components, and from a physics perspective, the way this blood is flowing in these pressures and jetting can't be good. And of course, it's supported by elevated levels of globin levels. If you look at pulsed versus non-pulsed in that retrospective review, the globin levels were much higher in those patients where pulsations was being performed on the cardiopulmonary bypass, but the patients did not do better. In fact, they didn't do as well. So I think that's really the point.
Very little changes.
And thanks, Joe. Great presentation. Thank you. Centrifugal pump or roller pump? Which one is better to use during pulsatile flow? Neither. There's my answer. Neither. Don't do pulsatile flow. Don't do it. It doesn't work. My strongest recommendation is to absolutely not attempt to do pulsatile perfusion with a cardiopulmonary bypass circuit, because it does not produce a pulse that is in any way physiologic or normal or resemble anything normal, and all you're doing is creating more harm than good, and that's not what we're there to do. What is the difference between conventional ultrafiltration, modified ultrafiltration, zero balance ultrafiltration? A lot. That's a whole different topic for a different day. Very good question. But cuff and muff and Z-buff are all different things. We'll do a topic on that, or you can reach out to me personally at contact@perfusioneducation.com, and I'll send you a good video on that. In fact, Vicki is an expert on that. I think she has a lecture that you can get for that. And I think that's it. I think we're done. We went a little bit over. Please forgive me. That'll make the board happy to make up for the times that we're short. We'll see you all next time for Perf Web 91, where I bash and talk bad about people that rap, and hopefully we'll have somebody here that really thinks rapping is great. The only rapping there is the rapping that Snoop D-O-double-G does, and I don't even like his songs, so I'm definitely not going to like rap. I'm going to put my mega hat back on. Alwad, you're welcome. Send me an email. I'll send you the link. But here it is. Make education great again. See you later.